examining the knee, we normally look at the normal alignment of the patient, so having a quick overview. So we're looking at the general muscle tone, looking for any atrophy, looking at the patient standing, whether there's any antalgic gait, starting with the feet, looking for the position, if there's any pes planus, pes cavus, if the tibias are internally or externally rotated standing, looking at the levels of patella and the position of the patella, and seeing if they're symmetrical. Look at muscle bulk coming up, seeing if there's any atrophy. Check the level of the ASISs, and you can see if they're symmetrical on both sides. Looking posteriorly, look at the level of the PSISs, looking at the level of the knee creases bilaterally, looking at the position of both the Achilles and the muscle bulk of the gastrocnemius. Following that, look at the patient's gait. Ask you to have a walk up and back. So barefoot, looking to see if there's any antalgic gait, if there's any drop foot, high stepping gait, anything that would indicate neurological injury. See if the patient is able to perform it, making sure they've got appropriate muscle bulk and looking for the position of their feet and they're not turning outwards as they're walking up and back. If you now do a couple of functional movements, so if you can stand, put your feet shoulder width apart and form a double leg squat for me. So looking at A, is the patient able to perform it? And again for me, B, the position of both the patella as they perform it, making sure there's no J tracking present, position of the feet, to see if there's any overpronation as they perform, the range of movement, and if they're able to actually functionally perform it without losing their balance. We then move on to more dynamic testing, so we're looking at single leg squat. Start with the left, looking at the same things, and again more if they're able to get the range of movement and the balance now, if they have the appropriate strength. And on the opposite side, if we want to test them, we can always think about putting them on a wobble board to really stress that balance issue. Have a seat for me. So starting with the inspection then, we'll compare both sides. Globally, we're looking for any atrophy of the quadriceps muscles. Moving inferiorly, looking if there's any swelling, any effusions present, any bruising, any scars, neural old. Looking at the position of both the patella where they're sitting and resting, and the position of what their tibia are doing, whether they're internally or externally rotating, whether it's the same on both sides. Following this, then move on to palpation. So we'll palpate on both sides, quadriceps, muscle bulk, quadriceps tendon. Feel the patella. You can feel by putting downward pressure on the patella if there's any effusion present, but with a sweep test. Then look at the movement of the patella. So we'll perform a lateral glide, particularly looking for any apprehension or instability of the patella, and perform that on both sides. Feeling palpating specifically the inferior border of the patella, looking for pain, and then the patella tendon, and moving more inferiorly down onto the tibial tubercle. Then feel the hamstring tendons medially and laterally, before having a feel of the joint line, feeling for any obvious swelling or any pain when we palpate on the medial and lateral aspects. Then have a feel of the head of fibula, feeling for any pain or any tenderness, and then on the pes anserine insertion. With that, then move on to active range of movement, and we normally clear the joint up above and below. But what we'll ask the patient to do is perform a straight leg raise, keeping your leg straight, lift it as high as it will go, just for assessing and ensuring there's no neurological symptoms in the distal aspect of the limb or any involvement of the hip. All okay?
Yeah.
And then we'll check active range of movement of the knee. So can you bring your knee up and your heel to your bottom? So looking if the patient has full range of movement, if there's any discomfort when they're doing so, or if there's any of this clicking crepitus and straighten your knee. Put my hand under to ensure they gain full extension. And then we'll compare to the other side. So again, straight leg raise as high as it will go. And back down. And bring your knee to your bottom and your heel to your bottom, your knee up. Full range of movement, and then straighten your knee. Push down against my hand to ensure you get full range of movement. And relax. Moving on to passive range of movement. So palpating over the joint as we do so, feeling for any crepitus or any pain as I do so. Inflection and feeling for a soft end feel. And ensuring the range is as we'd expect. In full extension, same. Then moving to 30 degrees of flexion, test tibial external and internal rotation. Compare on both sides. Range of movement to extension, and then again tibial rotation. Internal and external. Check muscle power. Bring your leg up through all the range of movements. Can you straighten your leg for me? Push out against me. Keep going. Checking to ensure the power is grade 5 as we'd expect, and bring your heel to your bottom. Keep going. All the way ensuring that you have the same power through the whole range of movement. And straighten your leg. Comparing to this to the opposite side to ensure it's the same. Straighten your knee for me. And bend your knee. Keep going, keep going. And straighten for me. Then move on to special tests. So I normally will start with a Lachman to assess the stability or laxity of the ACL. So supporting the femur, providing an anterior draw to the tibia, feeling for a firm end feel of the ACL, and then comparing to the opposite side. Following this, testing the MCL, whilst palpating over, feeling for pain, apprehension and laxity, and then the LCL. Now I usually examine Murray's, looking for meniscal testing. So providing a force up into the knee whilst flexing and externally rotating for extending. And then the reverse for the medial meniscus. Then compare to the opposite side. Bring both your heels up to my hand, and provide an anterior and posterior draw. So supporting both the legs by sitting on them, and an anterior draw to feel for the laxity of the ACL, and then a posterior draw. As we do so, we have a look at the skyline view to ensure there's no subluxation to give us a false positive for a PCL or ACL injury, and compare the opposite side. And if I use have a roll over onto your front, here we'll perform the dial test looking for a posterior lateral corner injury. So bringing both legs up to 30 degrees. Passively externally rotate, looking for symmetry in the range of movement. Keeping this here, bring up to 90 degrees, externally rotate, and then we're comparing to see if there's still that symmetry. If we've lost that symmetry, then it's indicative of a potential posterior lateral corner injury. And relax back down, and come have a seat. Finally, we always consider the joint above and below and the neurovascular status of examination, in addition to patient's footwear and equipment, especially with lower limb injuries.